Dear students, I welcome all of you to this INI-CET November 2024 exam dermatology question discussion. So under dermatology, we had the following topics. Number one question from papillosquamous disorder, 3 from the topic of infections, 2 from the topic of sexually transmitted infections, and 1 miscellaneous topic. Let's start with the first topic from papillosquamous disorder. Here we had a question from psoriasis. Which of the following does not distinguish psoriasis from other arthropathies? Diarrhea, B. Dactylitis, C. Enthesitis, and D. Nail biting. The correct answer for this question is option number A, diarrhea. Now, when I'm looking at psoriatic arthropathy, the first point I need to remember here is that it is an example for seronegative arthropathy. So when I say seronegative arthropathy, students, it means that there are no specific autoantibodies in the blood. And apart from this, we're looking for some other important features. Number 1, dactylitis. Now, what is dactylitis? Dactylitis is uniform inflammation and swelling of the digit. So, uniform inflammation and swelling of the digit is called as dactylitis. So, this is an important feature of psoriatic arthropathy. The second important salient feature of psoriatic arthropathy is enthesitis. Now, what is enthesitis? Enthesitis is inflammation at the attachment sites. This is a very important word to remember. It is the inflammation happening at the attachment sites of a tendon, ligament, or fascia at the bone. So these insertional sites get inflamed in a condition called enthesitis. Another important point in favor of psoriatic arthropathy. And thirdly, you're going to have the presence of nail dystrophy. So since these 3 features are in feature of psoriasis, the correct answer for this question was diarrhea. Now, there is a classification criteria for psoriatic arthropathy, which is called Casper criteria. As per this Casper criteria, what is an entry criteria or a major criteria which should be there is an established inflammatory articular disease. When I'm saying articular disease, it could be peripheral arthritis in the form of joint involvement, could be axial arthritis in the form of spine involvement, or enthesitis. So all these 3, one of them at least should be there in the form of an inflammatory articular disease. So enthesitis comes in the major criteria. Apart from this, as a minor criteria, we have to obtain a score of 3 based on the following categories. So number 1, evidence of psoriasis. So when I say evidence of psoriasis, if a patient currently has psoriasis, we assign a score of 2. This personal history of psoriasis, then it is score of 1. Family history of psoriasis is also a score of 1. The second point is typical nail psoriatic dystrophy. So when I say nail dystrophy, 3 important changes have been mentioned. Number 1, we have nail pitting. Number 2 is the presence of subungual hyperkeratosis or hyperkeratosis, which is happening at the level of the nail bed. And lastly, we are going to have distal onychomycosis. So these are 3 important features which have been mentioned in the nail dystrophy. Third important feature which I mentioned to you is dactylitis, the uniform swelling of the digit. Negative test for rheumatoid factor, that's why it is seronegative arthropathy. And lastly, radiographic evidence of juxta-articular new bone formation. So nail dystrophy, dactylitis, negative test for rheumatoid factor, and radiographic evidence of juxta-articular new bone formation have been given 1 point each. So out of this, at least 3 should be present together with the major criteria. That would be the Casper criteria for psoriatic arthropathy. We take up the next topic on infections. We look at the first question from infections. A 60-year-old female with grade 2 nail infection. She's got significant discoloration with subungual hyperkeratosis, which has produced surface changes. She is suspected to be having onychomycosis. Now, what is onychomycosis, students? So, onychomycosis is fungal infection of the nail unit. Fungal infection of the nail unit is called as onychomycosis. The question is asking, which is the topical drug given in toenail onychomycosis? This is a relatively new question. Let us try to see how do we eliminate options in the exam. Option number A is itraconazole. Please remember, students, itraconazole is an oral drug. So it cannot be used topically. Option number C is griseofulvin. Generally, when we study griseofulvin, we are going to be reading it in the context of tinea capitis. So it is regarded as the overall drug of choice in tinea capitis. And we can also use it in dermatophytes as well. But then please remember, students, that this is also a oral drug. When we look at option number D, caspofungin. So caspofungin belongs to a group of drug called as echinocandins. So they belong to a group of drug called as echinocandins. Generally, we use echinocandins in invasive fungal infections, like invasive aspergillosis or invasive candidiasis, or generally the Candida species apart from albicans. We may have to use the echinocandins like caspofungin, anidulafungin, and micafungin. So when we're using it in invasive diseases, the route is going to be parenteral. That means it is generally going to be administered by IV route. So by the only way of elimination, the correct answer for this question is option number B, tavabarole. Now for future purposes, let us learn a little bit about this condition. Now tavabarole has been FDA approved as a topical antifungal agent in onychomycosis. Now, how does tavabarole act? So, it basically is going to target the leucine transfer RNA synthetase. Now, what is the function of this leucine transfer RNA synthetase? It catalyzes the attachment of leucine to its respective transfer RNA. So, once the attachment between leucine and its transfer RNA is not going to happen, what is going to happen? There is going to be inhibition of the fungal protein synthesis, and due to this inhibition, there is going to be cell death and there is clearance of the nail fungal infection. So this is going to be an important potential question in the exam, which is tavabarole. Let us now look at some topical antifungals in onychomycosis. First, we have 5% amorolfine, 8% cyclopyroxolamide. So these two drugs are available as nail lacquers. This is a form of new drug delivery system where nail lacquers or nail paints are used. This helps in sustained drug delivery release. And apart from this, we have tavabarole in 5% and efinaconazole, which is 10% solution. So these are some important drugs we need to remember for future in onychomycosis. Let's take up the second question from infections. A gardener from Himachal Pradesh presents with nodulo-ulcerative lesions on the upper limb. Axillary lymphadenopathy is present. Aspiration microscopy findings are shown below. What is the most likely diagnosis? So on aspiration microscopy, we see this is the LPCB mount, which is the lactophenol cotton blue mount. And what do we see on this mount is the presence of conidia, which are arranged in the form of a rosette or a daisy-like pattern. So these are the conidia, which is arranged in the form of a daisy-like pattern. And this is very characteristic of sporotrichosis. Now, please remember, students, that sporotrichosis is also called as Rose Gardner's disease, as the gardener is mentioned in the question. So this is also giving us a clue. So how do patients generally present over here? The characteristic history of sporotrichosis is going to be gardener with history of thorn prick. After thorn prick, you get nodulo-ulcerative lesions. Then there is proximal extension and linear pattern of lesions along the lymphatics of the extremity. Because this organism has an affinity for the lymphatics, that is why you get linear pattern of lesions along the lymphatics of the extremity. We move on to the next question. Which of the following is transmitted by walking barefoot in the soil? Option A, Madurella mycetomatis. Option B, Curvularia. Option C, Nocardia brasiliensis. And option D, Aspergillus fumigatus. The correct answer for this question is option number A, Madurella mycetomatis. So Madurella mycetomatis produces a disease called as eumycetoma. Generally, when we learn mycetoma, all of us know mycetoma is also an example for implantation mycosis. This is an example for implantation mycosis. That means here there has to be a traumatic inoculation of the fungus which happens into the skin from an external source, which is generally from decaying vegetarian matter. And in this context of mycetoma, generally we learn the triad of mycetoma. So you can see the foot here and you can see the huge swelling over here, which is called as tumefaction. So tumor-like swelling, this is the first component of the triad. Second, we have some healed sinuses, which is the second component. And generally, the third component is going to be in the form of discharging granules. And always remember, students, if somebody asks you, what are these granules? These are colonies of the microbe. These are going to be colonies of the microorganism. So, two questions from implantation mycosis, that is mycetoma and sporotrichosis, again re-emphasizing as to how important is fungal infections. We take up the next two questions from sexually transmitted infections, extremely easy this time in the exam. Which organism is not associated with urethritis in men? Now, when you're looking at urethritis, we know urethritis is defined as inflammation of the urethra. And this is broadly divided into gonococcal urethritis and non-gonococcal urethritis. So gonococcal urethritis is produced by Neisseria gonorrhoeae. So option number A cannot be the answer. When we look at non-gonococcal urethritis, we have Chlamydia trachomatis D2K serova. This is the most common organism producing non-gonococcal urethritis, followed by urea plasma, urea lyticum, Mycoplasma genitalium, Trichomonas vaginalis. So this is exactly in the order in which I generally take in our video lectures. So most common organism is Chlamydia trachomatis, and please remember D2K serovars, because L1, L2, L3 serovar is going to produce LGV. So Trichomonas vaginalis cannot be the answer. Mycoplasma genitalium cannot be the answer. The correct answer for this question is option number B, Gardnerella vaginalis. Now Gardnerella vaginalis produces a disease called as bacterial vaginosis. So what is the concept of bacterial vaginosis? It is characterized by altered vaginal microflora. So altered vaginal microflora means lactobacilli is going to be less and anaerobes are going to be more in number. So this is why there's no partner treatment required in bacterial vaginosis, because it is altered vaginal microflora is the concept of this condition. Please remember, some students did mark Trichomonas vaginalis in a hurry. Always remember, many students think Trichomonas vaginalis produces only vaginal discharge. Please mark it in your notes. It also produces non-gonococcal urethritis. Take up the next question. A woman presents with foul-smelling discharge. Examination of the cervix is normal. Whiff test is positive. What is the diagnosis? This is a straightforward question. The correct answer for this question is bacterial vaginosis. Now, what is this whiff test, students? So please remember, whiff test is also known as amine test. Whiff test is also known as amine test. How do we perform this test? We have to take vaginal discharge on a glass slide. And up to this, what do? We add 1 to 2 drops of potassium hydroxide. As soon as you add potassium hydroxide, what will happen in bacterial vaginosis? There's liberation of volatile amines. Volatile amines are liberated, which have a fishy odor. Some important names to remember are putrescin and cadaverin. So putrescin and cadaverin are two important names you can remember as which amines are liberated. And these liberation of these amines are very characteristic of bacterial vaginosis, and they are important in the production of this fishy odor. And this whiff test or this amine test is also part of an important criteria called as Amsel's criteria. So we know, students, in the last examination, there was a question from Nugent score. And it goes without saying that there is definitely going to be one question from the topic of vaginal discharge. So I request all of you to read this topic in detail. So Amsel's criteria, there are 4 points. 3 have to be positive for the correct diagnosis of bacterial vaginosis. So first, it talks about the vaginal discharge, which is homogeneous, white, adherent discharge. So this is point number 1. Point number 2, the vaginal pH more than 4.5. That is point number 2. Point number 3, the presence of clue cells. Clue cells have been asked multiple number of times. They're basically vaginal epithelial cells with a stippled border, because these vaginal epithelial cells are totally covered by the Gardnerella vaginalis. And please remember, one more thing which is usually missed by students is more than 20% should be there on wet mouth examination. So please remember, when you selectively read many times, you just read the points, you forget this point. Please remember, more than 20% should be there on wet mouth examination. And lastly, whiff test should be positive, which I just explained, which is also part of the amine test. So out of these 4 points, 3 have to be positive for the diagnosis of bacterial vaginosis. Moving on to the last question from miscellaneous topic. Which of the following is false pertaining Behçet's disease? Now, we know 2 things about Behçet's disease. From a dermatology point of view, it is a neutrophilic dermatosis. So we classify it as neutrophilic dermatosis. So this is point number 1. And point number 2, always remember, Behçet's is an example for vasculitis, and it's an example for variable vessel vasculitis. The classification of Behçet's is going to be variable vessel vasculitis. That means it can also involve the small vessels, medium vessels, and large vessels. So what question was asked about Behçet's? Which of the following statements is false? Option A, bilateral panuveitis, correct. It can produce iridocyclitis. Option C, more associated with Crohn's than ulcerative colitis, is also correct. Pathergy test is positive is also correct, because pathergy is a hypersensitivity response to intradermal injection or to scratch. So any form of scratch or intradermal injection that we do, saline injection, can produce a hypersensitivity response when pathology can be positive. The correct answer for this question is ulcers are seen usually on the dorsum of the penis is the wrong answer. Usually, the most common site of ulcers in Behçet's disease is scrotum. With this, we complete our discussion of the INI-CET questions from dermatology. Wishing you all the very best for the upcoming FMG exam as well as the NEET PG exam. Thank you.